Yes, greetings everyone. Welcome to it. So today we are here for Journal Club with authors, and it is our third one. As you can see, there are two others that we have already gone through, so you can watch those anytime. On Oral Pathology 360, we get together once a week on Tuesdays and once a month now on Saturdays to learn and discuss on all matters relating to the oral and maxillofacial diagnostic sciences and, of course, to make new connections. I'm Dr. Mandana Donahue, founder of Oral Pathology 360, and it gives me a great pleasure to introduce today's host, which is Dr. Puyan Amini Shakib, and he is managing uh, this episode. So let me bring him in. And yes, welcome, Dr. Puya.
Okay, thank you. Hello, everyone. I would like to welcome you all to the third online journal club. I'm Puyan Amini Shakib, co-host of the program, and it's a great honor for us to have Professor Lester Thompson from United States today in this program, and also uh, my friend Dr. Hannah Safar. Uh, Hello, Professor Thompson. Thank you for
Good evening. How
accepting
are
our
you?
invitation.
My pleasure.
We're pretty good. And Dr. Safar, thank you for joining us in this program. I was glanced at the Professor Thompson CV yesterday, but I think it takes more than one program to present introduce Professor Thompson in this program, and then I think no doubt that all of the audience well know Professor Lester Thompson. He's uh, author of many textbook, and also he's the author of many impressive and influential paper in the pathology, especially head and neck pathology. And Please let me immediately go to the program and express again my sincere gratitude to Professor Thompson for joining this program. Furthermore, we have two of enthusiastic, talented residents, Dr. Mina Moradi and also Dr. Kiana Anusha, in this program. The title of the paper in this program is Predictive Value of Tumor Budding in Head and Neck Squamous Cell Carcinoma and Update. Okay, I think we are ready to get started the program with the first presentation by Dr. Mina. We are ready, Dr. Mandana.
Hello everyone, I would like to thank you all for your time. I am very pleased to be here. I am Mina Moradi, resident of Oral Pathology at Tehran University of Medical Sciences. Today, I look forward to discussing a review article about predictive value of tumor budding in head and neck squamous cell carcinoma, written by Professor Carlos Miguel Chiesa and Professor Lester Thompson et al. Okay, let's start with introduction. Head and neck squamous cell carcinoma forms an anatomically and functionally complex group of malignancies, with over 375,000 annual deaths worldwide. It ranks as the eighth most common cause of cancer-related death. Surgery, radiotherapy, and chemoradiotherapy, either alone or in combination, are the primary treatment options. The 5-year survival rate for patients with head and neck SCC is about 50% and has not changed much over the previous 20 years, except for HPV-associated or pharyngeal SCC. Research is still being conducted to find more sensitive and dependable prognostic and predictive biomarkers because of the notable local aggressiveness and regular regional relapses. Conceptually, tumor budding is defined as a continuous phenomenon in which single cells and isolated tumor cell clusters, up to 4 cancer cells, detach from the main tumor invasive front and invade into the adjacent tissues. Despite ongoing debate, a trend has been made to further stratify tumor budding into low, intermediate, and high score categories. EMA published the first description of tumor budding and its association with disease progression in solid tumors in 1954. Notably, tumor budding has been linked to a number of cancer types, including head and neck SCC, as a potential prognostic factor. This is likely because of interaction between cancer cells and the tumor microenvironment and their effects on the epithelial to mesenchymal transition process, which could provide a histological foundation for evaluating local invasion and metastasis. In 2019, a systematic review and meta-analysis by Zhou et al. On 13 studies found that tumor budding was present in approximately 29% of head and neck SCCs. They also reported that high score more than 5 buds in their analysis, tumor budding was associated with a significantly increased risk of lymph node metastasis and worse overall survival.
Thank you again. And Professor Thompson, do you have any comment to commence the discussion of the role of tumor budding assessment in oral squamous cell carcinoma? And then I will share some questions with you.
Yeah, so I will say that in my practice, it's always nice to incorporate new techniques or new assessments, biomarkers in this particular case, if we can utilize that particular term, to try and get what is a better prediction of behavior of that particular tumor for the patient, to be able to suggest alternatives in therapy if that's going to be of value to the patient. So I will say, that the idea of tumor budding being assessed in the various anatomic sites with squamous cell carcinoma in the head and neck is very promising. But I have to say immediately that there is not a consensus, right? There is not yet a well-defined way in which to assess tumor budding as a whole, and whether or not to provide a standardized grading for these, whether we're using a 2-tiered grading system or a 3-tiered grading system, in order to be able to facilitate stratification of these patients that allow them to be better managed. So I do feel it is still in development. I don't know that at this particular time we can sort of obligate everyone in the world to report it, but I do think
Mm.
potentially within the next 3 to 5 years, maybe we will be able to have a much more robust way in which to be able to evaluate this as one of the potential prognostic markers of suggesting lymph node metastasis. I mean, I think that is probably the single highest benefit of this is lymph node disease. Not necessarily long-term patient outcome, although there have been some studies that show that disease-free survival, overall different story and a different result with each of them. But I do think if we are trying to predict which tumor, when we look at it, is more likely to be associated with lymph node metastasis, and
Mhm.
therefore what would be the appropriate management of the neck, is really the driver here for me. Anytime you do lymph node dissections of the neck, there's always morbidity for the patient that is obvious and something that they have to live with from then on. And so, if we're able to limit that particular procedure to the patients that are more likely to benefit from it because they have a higher risk of metastatic disease, that's the ultimate goal here.
Okay, great. And Dr. Safar, do you have any comment or questions you'd like to share with Professor?
I'm looking to the comments, and there's one question regarding possibility of tumor budding in the next CAP protocol for head and neck squamous cell carcinoma. As you know, there is no consensus regarding this matter, and there is no tumor budding mentioned in CAP current classification for head and neck squamous cell carcinoma. But dear Professor Lester Thompson, do you think in the next classification we will see tumor budding as one of the things that we should report in our pathology report, or do you prefer to have any comments for particular patients that you see some kinds of tumor budding in their slide in your synapse?
Yeah, it definitely is not in the current CAP guidelines, and I can tell you I am working with the International Cancer Collaboration, or International Collaborative Cancer Reporting (ICCR), and for that particular series, it is out actually for public comment right now, and we have not included it at this particular time as a mandatory item to report because there is still insufficient amount of data to say that it is going to be absolutely of value. So even still at this point, while that ICCR data set is being developed, we have not had agreed that the tumor budding must be reported at this particular time. So I think part of that is because which method are we going to use? So I think it's already been alluded to as Dr. Mina was discussing in the recording that kind of then disappeared for a moment. But, we reported ideas of having, five buds as being something that was considered a high grade. However, if you look at budding activity, grading should be less than 14 buds if you're looking at 2 square millimeters, and we're trying to get to that 2 square millimeter concept rather than just a single high power field or a single 20x field, because a 20x on your microscope, depending on what your optics are, is not mine. It's related to each individual field, and when you're looking at just a single one like that, where many of the reporting systems only have a single high power field to make that determination, even though it has been assessed on multiple fields and then choosing one hotspot location, I feel that there needs to be better standardization. So much in the world is going now to digital pathology. And on digital pathology, there is a well defined size. So I can say this is 1 by 1 millimeter. So I know exactly the space that I'm looking at. I'm not worried about the optics of the microscope. I'm not worried about objectives or anything else. So I feel that the standardization of how many buds are being looked at in a slightly broader area, the 2 square millimeter concept, which is the same criteria we use for mitotic index and Ki67 proliferation index, if those are the same parameters used, I think we'd have a very different number, right? Because now you're not going to have a cutoff of 3 or cutoff of 5 or 10 or 14
Mhm.
like other people have suggested over the last several years. So until that can be standardized, I may say this seems to have a high tumor budding and therefore may be associated with more risk of lymph node metastasis in a comment, but I don't know that I want to, at this time, mandatorily include it in a pathology report going out to a clinician.
Mhm.
Thank you. Thank you so much.
Okay, thank you, Professor. I think the problem is fixed and we are ready to um, uh, go ahead with the presentation of Dr. Minas.
Yes, I will just share it.
Also, El Sergi et al. Published another meta-analysis in 2022 examining the impact of newly developed histopathological markers revealed a correlation between tumor budding at both overall and disease-specific survival. Furthermore, there is evidence that high-score tumor budding is associated with a more aggressive malignant potential of head and neck SCC, along with a higher chance of cervical lymph node metastasis and also poor overall disease-specific and disease-free survival rates, especially in patients with early-stage oral squamous cell carcinoma. Data from other anatomical subsites and other solid tumor subtypes support the relevance of tumor budding in cancer, including colorectal adenocarcinoma, esophageal SCC, upper gastrointestinal carcinoma, breast cancer, lung SCC and adenocarcinoma, intrahepatic cholangiocarcinoma, gastric cancer, cervical and endometrial cancer, bladder cancer, and melanoma. According to the aforementioned studies, tumor budding is a relatively common phenomenon in the progression of cancer and may have a significant impact on patients' prognosis because it can offer important insights into the biopsy and clinical behavior of head and neck cancer. However, despite the aforementioned evidence, tumor budding has not yet been mentioned in the TNM classification, but it is included in the 2023 WHO classification of head and neck tumor. Here, we summarize the main viewpoints and ramifications of tumor budding in head and neck squamous cell carcinoma. Prognostic. According to multiple studies, patients with high-score tumor budding have a worse prognosis, which includes a higher risk of lymph node metastasis and a lower overall survival rate. This implies that tumor budding may serve as a valuable prognostic marker to inform treatment choices and predicting patient outcomes. The other one is therapeutic. The development of new treatments may be significantly impacted by tumor budding, for example, by focusing on the pathways that promote tumor budding in head and neck SCC. Furthermore, by comprehending the molecular pathways involved in tumor budding, new targets for drug development and customized therapies may be discovered. Additionally, using standardized protocols will offer a choice for directing treatment choices. So, what's the aim of this article? Our goal is to provide information about tumor budding in head and neck SCC. By shedding light on the complex biology of head and neck SCC and aid diagnosis, classification, and improve characterization, we hope to open up new possibilities for enhancing patient outcomes. Methods. Although this literature review didn't require approval from an institutional review board, but the methods used in this study were compliant with international ethical standards. So, discussion. Assessment of tumor budding in head and neck SCC. When evaluating tumor budding in head and neck SCC histological evaluation, there are two primary concerns to consider. The technique for scoring tumor budding, and the other one is the staining method chosen to assess the samples. About the techniques used in head and neck SCC to score tumor budding, Virchows et al. Recommended counting the number of buds in a single 40 high-power field after scanning 10 high-power fields in areas showing maximal budding on a hematoxylin and eosin stain slide. Virchows et al. Also suggest evaluating budding activity. which indicated that low budding activity was defined as 1 to 4 budding nests, high budding activity as more to equal 5 nests in a single high power field. Low budding activity was scored if 1 to 14 and high budding activity as more to equal 15 nests in 10 high power fields. A method suggested by the International Tumor Budding Consensus Conference (ITBCC) is to scan 10 individual fields at 10x to determine the tumor budding hotspot and then counting the number of buds in a single 20x field of view normalized to a 0.785 square millimeter value. In terms of staining techniques, tumor budding has been assessed using histological slice stained either with immunohistochemistry for pancytokeratins or with Ejanian staining. Although there isn't much proof or agreement on which approach is best, some research on oral SCC have shown that cytokeratin ISC performs better than HNE. Similarly, Kayatol observed that IC staining for cytokeratin was more useful when the histological evaluation was performed by an inexperienced pathologist or a pathologist who didn't have enough confidence in the evaluation of tumor budding. It is crucial to understand that a number of complicating factors, including pseudobudding, limited areas for tumor budding assessment in the biopsy samples, and ambiguous results due to severe inflammation that restricts the interpretation of tumor budding on conventional stains, may have an impact on the budding score. In fact, it is in the latter setting where IEC evaluation may be more reliable than HNE alone. Additional research is required to enhance the utilization of both methods in clinical settings and aiming to identify the most efficient scoring system for use in head and neck SCC, perhaps looking to the ITBCC to yield the most meaningful clinically actionable recommendations. In trying to establish a risk stratification system for patients with head and neck SCC based on the number of buds, different cutoff point values have been suggested. However, at present, it seems that a two-tier system of up to 4 buds and more or equal to 5 buds, considered low risk versus high risk, respectively, shows the most promise. Furthermore, another relevant factor to consider in the assessment of tumor budding in daily practice is both inter-observer and intra-observer reproducibility. Thus far, there is good to excellent intra-observer and inter-observer reproducibility, suggesting feasibility of including tumor budding in tumor reporting and cancer staging systems. Thank you all for your attention.
Okay,
Yes,
uh,
1 second.
don't worry.
Oh, this is, there you go. Okay.
Okay, great. We are on a stage again. But let's quickly start this part. Thank you, Dr. Mina, for your great presentation. Professor Thompson, it seems the problem is mostly about the assessment of the tumor budding and reporting and risk stratification of this important finding. Do you recommend to use to exploit the IHC study to assess the presence or absence or counting the tumor budding in all cases, or it might be necessary in special cases?
I don't recommend the immunohistochemistry at this particular time. You know, if you go back, and since we just heard that presentation, the inclusion of the International Tumor Budding Consensus Conference, which is what the ITBCC stands for, That particular organization had met specifically for colorectal tumors, but that was in
Mhm.
2016, with the findings of that group reported out based on levels of acceptance and standardized levels of reporting from the various members that participated in that particular conference. Came out, I think, in Modern Pathology in 2017. So for that particular article,
Mhm.
they were very specific about what it is that they did and what they recommended for people to do. So their very first comment is it is something that should be counted on H&E alone. So if we're going to, at least at this early stage, try to build on the recommendations of the same findings in other anatomic sites, then we shouldn't go to having additional studies performed. So I would rather not see the utilization of immunohistochemistry, because then, well, is it a pan cytokeratin? Is it AE1, AE3? Are you using CK1? Are you using
Mhm.
Oscar? What is the study that you're going to perform? And now this opens up an entirely different kettle of fish, so to speak, because how do you then account for cytoplasmic pseudofragments, right? That's one of the problems that you see. There'll be fragmentations and you just have cytoplasm. Well, does the cytoplasm actually therefore count by itself? And it would stain with
Mhm.
the immunohistochemistry for sure. I think all of you have done immuno and you'll see, a whole lot of scattered positive cells in a cyst that we just completely ignore and only go to look at an area of interest. So I do think that the pseudo fragmentation concept is going to be quite challenging to be able to
Mhm.
evaluate. And there has actually been a paper already talking about, that type of pseudo fragment idea. So I feel if at this juncture we're still in early development, stick with harmonization across all body parts. We may be
Mhm.
oral pathologists here, or you may be a head and neck pathologist, but um, the vast majority of people are general surgical pathologists like myself, right? So this means I sign out breast cases and colon and melanoma and all of the rest of the anatomic sites much more frequently than I do head and neck. Those are the ones done in the evening. So,
Mhm.
if I'm using criteria all day for colon, my most difficult thing for colon is where is the hotspot? So,
Mhm.
the data that was presented was talking about if you have a biopsy. Okay, if it's a 1 or 2 millimeter biopsy, is this a sufficient amount of the tumor for me to give a depth of invasion or a tumor distance or a tumor budding score or a grade even? Do you grade on a biopsy? I mean, if it's poorly differentiated, probably we're all okay. But it's when it's well and moderately differentiated that we're like, oh, how do you know what's not in the rest of the tumor? So I think when we have the highest parameter present in the sample, we're not so hesitant to report it. But it's the clinician relying on the data because we don't have enough in the sample that is what causes us the most angst. So I feel that until we say, okay, the biopsy should be at least 5 millimeters in single longest lineal length on the slide. And if we
Mhm.
all agree that that's what it's going to be, none of this is done for colon carcinoma on a biopsy, right? If you look at
Mhm.
the biopsy, the criteria from the ITBCC, it is on a colon resection. And do you report the tumor budding if you already have metastatic disease in the liver or lymph nodes? No.
Mhm. Mhm.
So it is a predictive model, right? So this is a notion of let's get a prediction to suggest how likely are they to develop metastatic disease. So in the resection sample, if none of the lymph nodes are positive, that's when you would say, oh, you know what? This is weird because they have a really
Mhm.
high tumor budding index. This is going to behave more biologically aggressively. Let me give them that piece of data so that they can look at the liver a little bit more
Mhm.
carefully or look at other sites to make sure that it's not there. But it's always done, on a resection specimen. It's not done on a biopsy. So right now, if you have a resection specimen, quite frequently it's already had the neck done. So you
Mhm.
aren't actually now helping eliminate that particular procedure for the patient.
Mhm. Great, thank you. We have several questions from our participants, and Dr. Mandana, would you share them with us on the stage, and I will ask Professor. Uh, I will share them with the professor. Okay, are we going to track the tumor budding in juxtaepithelial or follow it until reaching deeper connective tissue like surrounding? I think it is about the where we can assess the tumor budding. Are we supposed to assess tumor budding at the deepest area of the tumor invasive front, or it could be assessed at the superficial area?
Yeah, at least at this particular point, the criteria are just at the invasive front. It's not defined. A depth of invasion is defined. Tumor thickness is defined for whatever those
Hmm.
parameters may be. We're not going to go there. Um, but they are not defined for anything more than invasive front. So I think anywhere
Hmm.
along that invasive front, and because you're looking along that entire front and in theory doing 10 or more high power fields to assess where the greatest number of them are,
Hmm.
means you may not be at the deepest point at that particular time. I'll just raise it here as well because many times tumor budding and worst pattern of invasion are quite frequently used in kind of the same notion of risk stratification. If you think about the worst pattern of invasion, which by definition is pattern 5, an offset
Hmm.
of tumor at least 1 millimeter away from the rest of the invasive front. So,
Yes.
um, if we're saying the invasive front is there, but I'm looking a millimeter away from that
Hmm.
in order to be able to say, oh, this is the worst pattern of invasion now, how do you assess that on a biopsy? And what if you were counting the tumor budding over here and not where you had the worst pattern of invasion, which, at least at this particular point, does actually have a good standing as far as predicting outcome for patients. So I feel that the advancing edge or the infiltrative front of the tumor is where it should be sought, but I can't tell you it's better superficial or it's better deep or it's better only at the deepest
Hmm.
part. Many times the deepest part has kind of a more rounded appearance, and it may be paradoxical maturation in a dysplastic area that just fills into the space, but it's so displaced into skeletal muscle within the oral cavity, at least, that it's clearly invasive.
Okay, great. Thank you. Dr. Safar, do you have any comment? Because
Uh,
of time shortage, we would like to go to the next video.
Actually, there is a question from Professor Hill. He
Mhm.
asked that is there any connection between tumor budding and preneural invasion and risk of preneural invasion?
I think both things can be seen, and good to see you, Josh. I think both can be seen simultaneously. I can't give a specific on the potential for if you have one, you're more likely to have the other, or the other way around. That I'm not able to answer.
And dear Professor Thompson, you have used the terminology of pseudo-fragmentation. Do you use it equal to tumor pseudo-budding in this context?
I think pseudo budding is different than fragmentation.
Would
So
you please
pseudo
explain a
budding,
bit
yeah,
about
is
pseudo-budding? Because in colon cancer, when we discuss about tumor budding, some kinds of distortion of glandular structures are seen, and we should be careful about that. But how about a squamous cell carcinoma? Would you please explain a bit about definition of tumor pseudo-budding and its differentiation from adjacent inflammation and the challenges that it will make for us?
I think for myself, the pseudo budding is most commonly conceptually identical to what we deal with necrotizing cell metaplasia. where in necrotizing salometaplasia, there is a well-defined gland or space. The squamous epithelium is filling into that particular space as it is advancing and gives the, impression that you may be dealing with an invasive tumor unless you still see that it's very, very well rounded. So I think here the pseudo budding is more related to a rounded appearance to it rather than being jagged or irregular in its appearance. So for me, when I look for it, it really needs to have an irregular profile to it to really qualify as a tumor bud rather than being nice rounded spaces as they are advancing down into the underlying stroma. So that for me is the best thing to say for pseudo budding. If you conceptually think about necrotizing salometaplasia, and if that crosses your mind, probably that is not a good example of a true tumor bud in this particular setting. Can I say one thing just about the WHO classification? Because I know that it was stated that it is actually part of the WHO. It isn't. It is in the WHO, but it's just saying tumor budding can be a prognostic factor, and it lists a whole bunch of things that can be a prognostic factor, including bone invasion and tumor to stromal ratio and worst pattern of invasion and depth of invasion, perineural invasion, lymphovascular invasion. So there's several different parameters that are all listed off, but it isn't as if it individually is given a lot of weight. I mean, it's included in a tabular form in the oral cavity chapter under squamous cell carcinoma. So I do feel that it is included as a thing to consider in squamous cell carcinoma, but it isn't as if it is being specifically stated you must report this. So I just wanted to clarify that. I mean, it's in the book, but a lot of things are in the book. You talk about pathways, you talk about different molecular alterations, you talk about things that happen within it, but you aren't telling people that they must have done all of those particular studies in order to get to the interpretation.
Thank you so
Okay,
much.
great. And Dr. Mandana, we are ready for the next video.
Okay, just sharing it.
Hello again, everyone. I'm Dr. Kiana Anusha, third year pathology resident of Tehran University of Medical Science, and I'm going to be covering the rest of the discussion. Let us start by discussing the accumulated evidence from systematic reviews and meta-analysis on tumor budding in head and neck SCCs. Tumor budding is mostly studied in oral SCCs. The first meta-analysis on this topic was performed by Al-Mangush et al. They demonstrated the association of high-score TB and lymph node metastases, as well as the correlation of TB and the presence of occult lymph node metastases in early-stage oral SCCs. Their study also proposed that TB has a greater prognostic power in comparison with routinely evaluated predictive markers, such as TNM, depth of invasion, or WHO tumor grading system. They also suggested the usefulness of a cutoff value of 5 watts. A statistically significant correlation between high tumor budding and decreased overall and disease-specific survival was observed in early-stage oral SCCs. Tumor budding was also considered as an independent predictor of lymph node metastases and overall survival in tongue SCCs. Evaluation of TB in biopsy specimen can aid in preoperative planning. Al-Mangush et al. Reviewed several studies on pre-treatment TB assessment of any tumor type and proposed the potential prognostic value of TB. Moreover, evaluation of TB in the first part of the primary tumor is correlated with tumor grading, depth of invasion, lymphovascular invasion, and pattern of invasion. Although there is no general consensus, several methods have been proposed to improve the accuracy of TB scoring. As an example, the recommended spot for TB evaluation on a biopsy specimen is better to have a horizontal margin of 8 mm and a vertical margin of 5 mm. Also, at least 3 biopsy samples are recommended for TB evaluation in colorectal cancers. However, there is no definite number for head and neck SCCs. Generally speaking, there is a good correlation between TB score in diagnostic biopsies and corresponding surgical resection samples. Moreover, the correlation between TB and the presence of lymph node metastasis, tumor grade, overall survival, and relapse-free survival was observed in oral SCCs. However, TB assessments in biopsies face limitations, including the amount of inflammation, the questionable possibility of pseudobudding, and the limited number of representative fields. The accurate biological aspects of tumor budding in head and neck SCCs remains to be studied. However, TB presence was related to the expression of E-cadherin and EMT-associated transcription factors such as SNL2. Increased expression of other EMT transcription factors like ZEP1 and PRX1, as well as TGF-beta signaling pathways, are also reported in the literature. Moreover, increased expression of aldehyde dehydrogenase 1 or CD44 as stem cell markers was correlated with high tumor budding in SCCs of head and neck. Additional markers such as TP53, which are frequently observed in head and neck SCCs, are also linked with decreased overall survival and improved TB development. Although poorly understood, the interaction of tumor front and the surrounding stroma plays a significant role in tumor progression. Moreover, tumor-infiltrating lymphocytes are now believed to impact the prognosis of head and neck SCCs. As mentioned earlier, tumor budding development is related to EMT, which is a necessary step for cancer cell migration and lymph node metastasis. An inverse correlation has also been observed between CD8-positive T lymphocytes and tumor budding. Decreased density of tumor-infiltrating lymphocytes are in correlation with a higher rate of lymph node metastasis and a higher TB score, according to some studies. Studies on subtypes of tumor-infiltrating lymphocytes revealed the relation of CD163 positive macrophages with tumor regional control, disease-free survival, and occurred lymph node metastasis. Also, a combination of TB and CD163 positive macrophages is a better predictor for regional recurrence in oral SCCs. High CD4 positive and low CD8 positive tumor-infiltrating lymphocytes, along with high CD68 positive macrophages, are also associated with higher score TB and increased angiogenic activity. Pei et al. Proposed the IBD score by combining the inflammatory response, tumor budding, and depth of invasion in order to aid risk stratification and prognosis evaluation of oral SCCs. Moreover, the correlation of higher score TB and reduced overall survival and disease-specific survival, as well as correlation of these factors with the risk of occult lymph node metastasis and recurrence, have also been demonstrated in this study. Till now, TB is proved to be a reliable and cost-effective prognostic factor. As an example, TB was included in histological grading of early tongue cancer by El-Saragil et al. The results show a good predictive power for disease-specific and disease-free survival. Evaluation of TB, whether at tumor front or at the periphery, was also predictive of cervical lymph node metastasis and prognosis in a study performed on temporal bone SCCs. Moreover, the limitation of WHO grading system has been highlighted by authors due to its subjectivity and low reproducibility. One study demonstrated that integrin beta-4 and laminin 5 localization at tumor stroma interface is correlated with increased tumor budding in head and neck SCCs. It is worth mentioning that evaluation of TB can be improved by additional computational tools. However, automated assessments are mostly studied on colorectal cancers, which include several methods of deep learning algorithms. Despite not always in correlation with pathological differentiation, TB is now considered an independent prognostic factor of lymph node metastasis and survival in oral SCC patients with clinical stage of T1 or T2 and N0. Studies on nasopharyngeal, hypopharyngeal, laryngeal, and even cutaneous head and neck SCCs showed a link between high tumor budding and cervical lymph node metastasis. Moreover, tumor budding was associated with advanced end classification, distant metastasis, and prognosis in laryngeal SCCs. We should bear in mind the importance of distinction between tumor budding and worst pattern of invasion. Worst pattern of invasion is classified into 5 groups, is assessed in all slides, and involves measuring the distance of primary tumor to the nearest tumor islands. To name a few controversies regarding TB evaluation, we could mention the lack of a reliable scoring system, especially in regard to different results when using IHC and H&E stained slides. This issue can be resolved by blindly scoring TB in the IHC and H&E stained slides separately and then comparing the obtained results. Moreover, HPV-associated SCCs and most of the HPV-negative basaloid SCCs are not prone to bud, and thus evaluation of TB is not only unrequired, but also can cause confusion. There is also no clear approach in scoring of biopsy specimens due to the absence of tumor fronts. In conclusion, TB not only has a significant prognostic role, but also can have a therapeutic implication in head and neck SCCs. However, considering the debatable scoring systems and variety of tumor size, further studies are required to confidently include TB in classic staging systems. And this brings me to the end of my presentation. I'd like to thank you all for your time and attention.
Okay, thank you, Dr. Kiana, for your well representative lecture. And let's immediately go to the discussion. Dr. Thompson, we have a question left from the first part of the program that Professor Hill shared questions about that. Do you think if there is any association between tumor budding assessment and perineural invasion in oral squamous cell carcinoma?
I think I had answered that actually, just saying that I could not give a specific number. I mean, I am sure that there is a correlation because if you have individual tumor cells, in groups of less than 4, the chance that they're going to be around nerves seems like it should be a correlation. But I don't know that there is a specific study out there right
Mhm,
now that is suggesting that particular finding, at
mhm.
least not to my knowledge.
Okay, and Dr. Safar, do you have any comment or question there?
Yes, I'm looking to the comments, and there's a question about differentiation between pseudo-botting and true ones that I think we asked from Professor. And dear Professor, I would like to have your opinion about correlation or association between association of tumor botting and the tumor infiltrating lymphocyte. And I would like to ask you whether you report the tumor infiltrating lymphocytes for all head and neck squamous cell carcinoma. Is there, because as you know, it's not mentioned in CAP protocol as obligate as a must criteria or item to use and or to report. Would you please explain a bit about the association of tumor budding and tumor infiltrating lymphocytes and about how you report it in your pathology reports?
That's a very complicated question because there are lots of different components. Um, as we already know, there's kind of an inverse relationship, right? So the lesser number of infiltrating lymphocytes that you have, the more likely you are to actually have lymph node metastasis, which is commonly seen when you have a higher score for tumor budding. I will say that at this particular juncture, I do not routinely incorporate tumor infiltrating lymphocytes as part of my report. Is something that we observe while we are reviewing the slides or the material. Um, but, for example, if you're talking, and I know this is specifically around oral pathology or oral squamous cell carcinoma, but if I look at tumor infiltrating lymphocytes in oropharyngeal cancer, in nasopharyngeal carcinoma, they are ubiquitous. Yet I don't comment on them at all. And we don't kind of risk stratify them either. So I do know that the idea of trying to use specific macrophage markers to be able to identify this group has some benefit to it potentially. But I still do not report a specific number of tumor infiltrating lymphocytes, either per high power field or per tumor nest or something like that. I just do not incorporate it in my daily practice at this juncture. I will just make a brief comment back to Dr. Kiana's presentation, specifically the reference to the article by Hori et al. With that particular study, they did use CD163 positive macrophages as a determining factor to separate between low, and then intermediate and high grade budding was combined. However, one of the other things that is important is they did use immunohistochemistry to identify the areas that were going to be counted. And then when they counted it, they actually encountered half a square millimeter at 20x and only a single high power field. So again, they as a group utilized a very specific parameter and very specific numbers to suggest that there was a finding. They didn't use any of the criteria as already stratified out for colon carcinoma. So, that one study certainly shows that there is some utility potentially, but all of the evaluation was image analysis, right? So it was not a pathologist looking at it, it was image evaluation of that particular finding. So, do you have image software at your facility that you can rely on? I don't. So this means that that particular paper, while it is highlighting that potentially there is some utility and value to this particular finding, is not daily reproducible in my own lab. So if I go back to the very first comment that we were speaking about at the very beginning, it should be on H&E with something that a pathologist can sit and use at their own desk without anything else. Hence, no immunohistochemistry being added, not having automation being added, not at this particular time having AI involved in its determination or any of these other parameters. So while they may be of value in the near future, until we can standardize them for our own determination, I think that this is, not so easy. I'll use another paper, the paper put out by Sung et al. In I think it was 2021 or 20, yeah, I think it was 2021. But they also used whole slide images, and they automated their particular evaluation. And they counted 700.452 square microns or something. I mean, it was a completely just arbitrary and very odd number for them to come up with the evaluation that they then divided into the overall tumor area to say, well, because we looked at the whole slide and not just 10 high power fields, and we didn't do 2 square millimeters, let's just take the whole tumor volume now and divide this front into the tumor volume. And oh, look, yeah, that 6 volume stratification actually had value, and the patients did worse. But, I cannot replicate that. I don't have a whole slide that I'm counting the entire whole slide with an image analysis software that allows me to then calculate the whole volume of the tumor and divide it out. So I think many of these papers that we are citing and including and talking about trying to get some modeling in place, they are all very much still in infancy, and people are trying to come up with what is going to be the best approach. But right now, I still don't think we can do it. And so, to answer your question of tumor infiltrating lymphocytes and their relationship to tumor budding, if I can't comment on tumor budding reproducibly, I'm definitely not going to comment on tumor infiltrating lymphocytes reproducibly either.
Okay, thank you. We have 1 minute left to the end of this meeting, and let me share the last questions about one of the most important part of the Dr. Kiana's presentation about the therapeutic implication of tumor budding. You well presented in your paper that the pathway of of the tumor budding aggregation at the invasive front of oral squamous cell carcinoma is very important to be assessed by the investigators. Is there any specific medication to target the pathway of the tumor budding, evolution, and do you know anything about the therapeutic approach of the tumor budding?
Yeah, no, I don't think that there is any clinical trial going on at this particular point. As you know, that epithelial to mesenchymal interface is very strongly correlated to the Wnt pathway. Just overall, I mean, this is the case for any of the head and neck related squamous cell carcinomas. And there are many different factors within that Wnt pathway that are well known. Some of them potentially can be targeted with therapies at this particular point, but I don't know that any one of them has been reduced to this is more likely to be associated with tumor budding, at
Mhm.
least not yet.
Yeah. Thank you very much. We must to stick to the time, and I would like to express my sincere appreciation to all of the participants to this meeting, and also it was an honor for us to host Professor Thompson, and also thank you, Dr. Safar, for being with us in this program. Dr. Mandana, would you please share the certificate of appreciation? Thank you, Professor. From
Thank
the
you.
beginning of from one more question. From the beginning of the program, I was searching for the tumor budding in the photomicrograph at the background of your. I think I have found something
I,
there.
yeah, if I stand away, it's in the background. I
Yes,
was covering it because I don't want people to look for it yet
yeah. Yes,
until we
thank you very
standardize
much.
it. Yeah, my pleasure.
Professor,
Have a
it was
good
a
day
great
ahead.
honor for
Thank
accepting
you.
our invitation. Dr. Safar, thank you for sharing your time with
Thank you
us
so
in
much.
early morning.
Thanks, Professor.
And
Yes,
You're
thank you
also,
welcome.
I
all
would,
for being here. And thank you, Professor Thompson. It was really a pleasure having you on the channel. And of course, Dr. Safar and Dr. Puyan are now a part of the channel. So, yes, thank you.
great,
Thank
thank
you.
you. And
Take
also,
care.
My pleasure.
would you please share the certificate of our talented residents with us? Okay. Thank you, Dr. Mina, Dr. Kiana, for sharing your time and your great presentation. And
Thank you
again,
for
I
giving us our
appreciate,
opportunity.
yes, welcome.
Oops, sorry. What happened? Why is everyone not there?
No problem.
Sorry.
And
Yes,
I
okay.
appreciate,
I think we
no
are
problem.
still all
Okay.
here, but in different time zones. You're still on Tuesday, maybe.
Yeah.
Yes, I am actually fixed on Tuesday, I think.
Have a good weekend,
Yes.
everyone. Take care.
Yes. You too.
Okay.
Have a nice time.
Great.
Take care.
And
Yes.
hope to meet you all in the next meeting that it will be held in 2 months. Thank you, Dr.
Yes.
Mandana. Have a nice day, everyone. Bye bye.
Thank
Thank
you,
you, everyone.
everybody.
Bye.
Have a nice day.
Bye
Take
bye.
care. See you all now on Tuesday.
Okay.
Bye.
Bye.
Bye bye.